Bismillahirrahmanirrahim. Today we will discuss nasal polyps. So what is in this picture? You can see broadening of nose due to nasal polyps inside the nasal cavity. In this picture, on anterior rhinoscopy, you can see polyp inside the nasal cavity. Now we come to our scenarios. 20 years old female presented with bilateral nasal obstruction for the last 2 years, history of seasonal allergy, operated for her disease 4 years back. On rhinoscopy, grape-like structures are seen in both nasal cavities. So these are the ethmoidal polyps. Question number 2. 12 years old boy presented with unilateral nasal obstruction, unilateral headache. On anterior rhinoscopy, whitish pale material is seen in right nasal cavity that is insensitive to touch. So it is unilateral and age of the patient is 12 years, no history of allergy, so it is enterochoanal polyp. So recall the anatomy of nasal cavity. You can see on one side there is one maxillary sinus and multiple ethmoidal air cells. These are the frontal sinus. So there are two maxillary sinuses, multiple ethmoidal sinuses and two frontal sinuses and two sphenoid sinuses. So edema and inflammation of the nasal cavity can be due to allergy or infection. So recall allergic phenomena, that is type 1 allergic reaction. There is formation of IgE antibodies due to exposure to certain allergens. These IgE antibodies get bound to mast cells, and on further exposure to allergen there will be antigen antibody reaction and degranulation of mast cells and release of leukotrienes. So these leukotrienes will cause inflammation and edema of the mucosa of the sinuses and nasal cavities. In case of infection, will lead to edema and inflammation of the nose and the sinuses. So there are two etiological factors, that are infection and allergy. So there are two types of nasal polyps. One is ethmoidal polyps and other is enterochoanal polyp. And the etiology is based on infection and allergy. So what is polyp? Polyp is any structure that is in the form of polyp, contains stalk and fundus. You can see stalk and fundus. So it is actually the herniation of the mucosa of the sinuses inside the nasal cavity, and this herniation is due to edema of the mucosa of sinuses. So on histopathology, based on etiology, if there is infection that is seen in enterochoanal polyp, there will be multiple neutrophils and lymphocytes inside the polyp. So there is edematous mucosa that contain fluid, and this fluid will contain neutrophil and lymphocytes in cases of enterochoanal polyp, and in cases of ethmoidal polyp, etiology is allergy, so these cells will be eosinophils instead of neutrophils. There will be few sinusoids, few that are the blood vessels without muscular cord, and there will be no neural tissue, and this polyp will be lined by ciliated columnar epithelium, that is the epithelium of nose and paranasal sinuses. So there will be stalk, fundus, lining will be of nasal mucosa and sinuses. There will be lot of fluid inside the polyp that will contain neutrophil in cases of enterochoanal polyp and eosinophils in cases of ethmoidal polyps. Few blood vessels without muscular cord, and there will be no neural tissue. So because of the absence of this neural tissue, polyp will be insensitive to touch, and because of few blood vessels, it does not bleed to touch. So pathophysiology is due to inflammation and edema, that can be due to allergy, that can be due to infection. Both of these conditions will cause obstruction inside the nasal cavity, leading to negative pressure inside the nasal cavity. This negative pressure will suck the edematous mucosa of sinuses inside the nose in the form of polyp. So this is the pathogenesis. In cases of endocrine, it is usually inflammation is usually due to infection, and in case of ethmoidal polyp, inflammation is due to allergy. So we have discussed the histopathology. So in cases of ethmoidal polyp, allergy is the etiological factor. So there will be sign and symptoms of allergy. So it is usually seen in allergic patients. Allergy is also related, asthma is also related to allergy. So patient will also have history of asthma. Family history of allergy will be positive. Sometimes ethmoidal polyps are also seen in certain congenital condition, that is cystic fibrosis. We will discuss this in the, later on. And sometimes there is allergy due to aspirin intolerance. Patient will be allergic to aspirin, and patient will present with ethmoidal polyps due to this allergy. Sometimes patient can be allergic to fungus. So this is seen in allergic fungal sinusitis, multiple bilateral nasal polyps. Vasomotor condition, that is vasomotor rhinitis, is due to hormonal imbalance, will lead to inflammation of the nose and paranasal sinuses and leading to ethmoidal polyps. So cystic fibrosis is autosomal recessive condition, and there will be absence of chloride in the sweat gland. So there will be no excretion of chloride ion. So diagnosis is based on the examination of the sweat, and patient will give history of thick mucid secretions inside the nasal cavity as well as in the lower respiratory tract. And on CT and X-ray PNS, you will see haziness in all sinuses. So patient will present in childhood. There will be history of bronchiectasis, there will be history of pansinusitis, and thick viscid secretions will be seen in the nasal cavities as well as in the lower respiratory tract. So in cases of allergy, polyp will be in ethmoid sinuses. There are multiple air cells, so polyp will be multiple, and allergy involve both nasal cavities, so these will be bilateral. So bulla ethmoidalis indicate anterior ethmoidal air cells, and these polyps can also be seen in posterior ethmoid cells, and they extend to the sphenoid as well as to the frontal sinus. They can also involve the maxillary sinus. So condition is bilateral, so there will be bilateral multiple nasal polyps. So diagnosis is based on history, clinical examination and investigations. So in cases of ethmoidal polyps, there will be history of allergy, history of sneezing, itching and clear rhinorrhea. Their family history of allergy will be positive. Some patients might have asthma, that is indication of allergy. So some patients can give history of seasonal allergy, some patients can give history of perennial allergy. So it is usually seen in adults because allergy is more common in adults as compared to children. As the disease is bilateral, so there will be bilateral nasal obstructions. Due to complete obstruction, there will be anosmia or hyposmia. Due to blockage of the sinuses, there can be infection, and due to sinusitis, patient can present with headache. There will be all symptoms of allergy, sneezing, itching and rhinorrhea. Due to bilateral blockage, there will be hyponasality. There will be absence of nasal twang in the speech. And on anterior rhinoscopy, bilateral grape-like structures, that is, these grapes are multiple, are seen in both nasal cavity. In this CT scan, so polyp will be insensitive to touch, it does not bleed to touch, and you can encircle the polyp with the help of probe. Color of the polyp will be pale in color. Sometimes if it extends to the orbit, there will be proptosis, and broadening of nose will lead to increase interpupillary distance, that is telecanthus. So on anterior rhinoscopy, all these findings, you can pick all these findings. So investigation to differentiate between allergic and enterocoinal polyp, you will advise blood CP. Eosinophil will be raised in cases of allergic reactions and neutrophil in cases of infection. In cases of ethmoidal polyps, there will be raised serum IgE levels. Skin prick test will be positive in atopic individuals. Atopy is the congenital predisposition to allergy. When you will examine nasal secretions under microscope with the help of hematoxylin and eosin stain, you will see eosinophils in the nasal secretions. Radiological investigations, you can see, you will advise X-ray, plain X-ray, that is Waters view, occipitomental view. You can see ethmoidal sinus, maxillary sinus, sphenoid sinus, and frontal sinus. There will be haziness of the ethmoid sinus, and all sinuses will be hazy due to bilateral allergic reactions. If there are lot of polyps on one side, they can push the septum to the opposite side. You can see, and these polyps can also be picked up by nasal endoscopy. Nasal endoscopy will show grape-like structures in both nasal cavities, and polyp will be multiple. MRI, you can see any intracranial extension that is usually seen in allergic fungal rhinosinusitis, and in this condition, polyp can extend to the intracranial cavity. This is enterocoinal polyp involving the maxillary sinus and that side of nasal cavity. So in cases of allergic polyp, both you will treat the allergy with the help of medicines, and you will remove the polyp with the help of surgery. So indications of medical treatment: if there is allergic rhinitis, allergic rhinosinusitis, and the polyps are small in nature, you can give medical treatment and polyp will regress in size. If patient refuses for surgery or surgery is contraindicated, you will give only the medical treatment. And after surgery, we will give medical treatment to control the allergy, otherwise there will be recurrence of polyps. So medical treatment will be in the form of antihistamines to control the allergy. We can also prescribe steroid nasal drops or nasal sprays, that is betamethasone, beclomethasone, flunisolide, and these nasal sprays are local decongestant, as well as they will make the mucosa insensitive to allergens. In severe cases, oral steroids can be given. Oral steroids are usually given in cases of asthma and severe allergic reactions. Short-acting nasal decongestant should be given, that is xylometazoline and oxymetazoline. Their effect is immediate, but they are short-acting, and it should not be given for more than 7 days. because of one condition, that is rhinitis medicamentosa, that is permanent hypertrophy of turbinates, and turbinates become insensitive to nasal decongestant later on. Systemic decongestant, ephedrine, pseudoephedrine can also be given, and nasal clearance, nasal toilet that can be done with the help of saline douching. So surgical treatment, latest treatments is endoscopic sinus surgery, that is also called FES. We remove the polyp with the help of endoscopes and microdebriders. We will clear all the sinuses, and recurrence rate is very low in cases of endoscopic sinus surgery. If you don't have endoscopes, then simple polypectomy can be done. Recurrence rate is very high in this procedure. If polyps are multiple and associated with some complication, external ethmoidectomy with this Lynch-Howerton can also be done. So ethmoidectomy can be intranasal, extranasal, transcentral, that is also called Jensen-Horgan approach, and endoscopic sinus surgery, that is the latest treatment. Enterocoinal polyp is the unilateral polyp. It arises in the maxillary sinus, and then it comes out of the natural ostia, and then it grows towards the choana, that is the posterior aperture of nasal cavity. So it has three parts: antral part, choanal part, and nasal part. Due to in cases of long standing polyp, the surface of the polyp can become there will be metaplasia of the surface epithelium, and it will be changed from ciliated columnar to the stratified squamous epithelium. So exact cause of enterocoinal polyp is usually not known, but it is usually seen in cases of chronic sinusitis. So it is commonly seen in children and young adults, and patient can present with unilateral rhinorrhea, unilateral pussy discharge, and unilateral sinusitis. So because maxillary sinus on one side is there is single maxillary sinus, so it is unilateral and single polyp. So you can on anterior rhinoscopy you can see single polyp on one nasal cavity that is insensitive to touch, and you can encircle the polyp with the help of probe. It doesn't bleed to touch, and you can differentiate it with turbinate, because turbinate is highly sensitive to touch, and you can't encircle the turbinate because it is attached to the lateral wall of nasal cavity. So clinical features are usually due to presence of polyp in one nasal cavity, so there will be unilateral nasal obstruction, absence of allergic symptoms, there will be no family history of allergy. If the polyp is long standing, it can push the septum to the other side, and there can be bilateral nasal obstruction. There will be hyponasality, absence of nasal twang in the speech. Symptoms will be unilateral sinusitis, that is headache, postnasal drip. So probe test is mandatory to differentiate it from turbinate hypertrophy and angiofibroma. Because it hangs in the nasopharynx, it grows towards the choana, posterior aperture of the nasal cavity, it hangs into the nasopharynx. Posterior rhinoscopy is mandatory. So if patient comes to you with unilateral nasal mass, posterior rhinoscopy is mandatory to see polyp inside the nasopharynx. You can see unilateral nasal mass. Posterior rhinoscopy will show mass in the nasopharynx, and the mass has pushed the soft palate downward. This is polyp, antral part, choanal part, and the nasal parts. So investigations are X-ray PNS, Then CT scan, you can see mass in one maxillary sinus involving the unilateral nasal cavity. Endoscopy, we can see mass with the help of endoscopes. Then you have to differentiate it with allergic polyps by IgE, serum IgE levels and blood CP test. So surgical treatment, simple polypectomy can be done. Cardwell Luck procedures, if dentition is complete, that is after 12 years, we can do Cardwell Luck procedures. Sublabial incision is given and hole is made in the anterior wall of maxillary sinus and the polyp is removed through this. This is Cardwell Luck procedure. Recurrence rate with Cardwell procedure is low as compared to simple polypectomy. Best and latest technique is endoscopic removal through natural ostia of the maxillary sinus, that is middle meatal and trostomy. So if you don't have endoscope, simple polypectomy can be done in children and Cardwell surgery in adults and in cases of recurrent disease. And infection is treated with the help of antibiotics. You can see unilateral enterochoanal polyp in this picture. These are the unilateral polyp, enterochoanal, multiple grape-like structures that are the ethmoidal polyp. These are the differences between ethmoidal and enterochoanal polyp. Enterochoanal usually seen in children, ethmoidal usually seen in adults. Infection is common in enterochoanal, but allergy is common in cases of ethmoidal polyps because it ethmoidal polyp arises in maxillary sinus, so it will be solitary. If allergic polyps arises in the multiple air cells of ethmoid, so these are multiple. So unilateral enterochoanal polyp, bilateral ethmoidal polyps. Origin maxillary sinus, enterochoanal polyp and ethmoidal sinus in cases of ethmoidal polyp. Ethmoidal polyp grows anteriorly but enterochoanal grows posteriorly towards the nasopharynx. So enterochoanal has three parts, antral, choanal and nasal parts, and ethmoidal polyps are grape-like structures. Recurrence is common in ethmoidal polyps because if we are not controlling allergy of the patient, their recurrence is high. In cases of enterochoanal, recurrence is low. So treatment of enterochoanal polyp is polypectomy. Best treatment is endoscopic middle meatal enterostomy and removal of polyp. And Cardwell duct operation is usually done in adults and in cases of recurrent, and it should be avoided in children. So in cases of ethmoidal polyp, medical treatment is very important because allergy control, we can control the allergy with the help of medicines. We can give preventive medicines, that is montelukast and sodium chromoglycate, and we can prevent allergy, otherwise there will be recurrence. So now we come to our